Welcome you here, and this is just a growing area inside of it, really inside of society in general, how we've thought about mental health. And we're moving along in aviation and updating that, and frankly we need to do more, and we are doing more, and that's why we're holding this seminar to let you hear about some of those challenges and issues. So I want to introduce the panel to you. So over here we have Penny Levin. She's a CFI, a clinical psychologist. She taught at Temple University, I think, and has given over 5,000 psychological evaluations. We're happy to have her. We have Chris Cooper, who works in our advocacy group, so he's probably our chief advocate or sort of point to moving inside the FAA to both understand what's going on and to advocate for things that we back. We have here Dr. Brent Blue. He writes for the AOPA magazine. You probably read his column, but he's also a senior AME. He's a HIMSS AME, and obviously a pilot himself, and so we're delighted to have him on the panel, and also really delighted that the Federal Air Surgeon, Dr. Susan Northrup, is here from the FAA, and thank you so much for your time today and joining the panel. And on the television here, we're piping in somebody named Gary Crump. Gary Crump, if you've ever called into the AOPA hotline for health issues, you've probably talked to Gary Crump. So he has a lot of insight on the kind of issues and questions that we get. So the way we're going to work the panel is, I've asked each of the panelists to have about 3 to 5 minutes somewhere in there for some opening remarks of whatever they'd like to talk about. And then we'll go from there. I have a couple questions that we've had from previous webinars that I'll tee up with, and then we're going to open the questions to you. There's some papers on the table there, and if you would like to write down your questions and fold them up and pass them to the front, my colleague John Collins and some others will pick them up and we'll ask the questions on your behalf. So, without anything further, let's just start going left to right, and Penny, we'll start with you. Welcome, and thank you.
Hi, thank you all for being here. So today we're basically talking about what I think of as the elephant in the room. Pilot mental health is the elephant in the room. Everything that I talk about with safety, everything I talk about with pilots comes down to safety. We know who is responsible for most GA accidents. Who is it? It's us. And I'm not going to tell you that pilot mental health is the whole reason that 70% of accidents are a result of pilot error, but mental health is part of it. Mental health problems have skyrocketed since the pandemic. As of last month, 22% of Americans in a national ongoing survey reported symptoms consistent with a depressive disorder. 29% reported symptoms consistent with an anxiety disorder. But that's them, that's not us, right? We're different. So Renee O'Shaughnessy is in the back, and she said, pilots believe that being vulnerable and sharing feelings or struggles, such as anxiety, depression, and chronic stress, would be at best humiliating or embarrassing, and at worst, the end of our flying careers. A major study done anonymously several years ago of airline pilots showed that 12% of airline pilots who had flown in the last 2 weeks reported symptoms consistent with a depressive disorder. These are guys, women, flying under a first-class medical. 4% reported suicidal thinking. And in 2019, another study showed at that point 18% of pilots met criteria for a depressive disorder. But again, that's not us, right? We reveal everything. We get treatment when we need it, right? We write everything on our medical forms, even with basic med. A recent study, and I'm a data person for people who have seen me present before, showed that, you ready? 56% of pilots avoided needed health care because of fear of not being able to fly, and 27% admitted anonymously to lying on forms regarding this. So that's the elephant in the room for me.
Chris.
Thank you, everyone. Chris Cooper, Senior Director of Regulatory Affairs, and what that means is I am not a doctor. So most all the other professionals up here, but as Richard mentioned, in my position here at AOPA, Government Affairs, our work that we do here is to advocate, right, for the improvement of working with the FAA and industry for improving regulations, policies, right, to allow for your freedom to fly, and to allow for more opportunities for individuals to be a part of the aviation industry. And so we know that this has been an issue that has certainly in the last few years, mental health issues have definitely become definitely a lot more public, and Penny has brought up a lot of good data. Actually, some of the data points I was going to kind of mention on here, and that is something that as AOPA we have really become attuned to for finding ways, right, to help improve the system and education for mental health issues in aviation. So maybe point off on some of the data points that I brought up, really from the way I view things and kind of moving forward with helping improve access and education, really kind of three big points that here at AOPA we're looking at, right? One is communication, right? Putting out more information either through our publications, webinars, what we're doing up here to help educate the public, right, about mental health issues. The second point definitely is to remove the stigma of mental health, and that kind of goes with education as well, too, right, to show, hey, we want to report. One of the big things that I think the FAA is going to talk about as well is get help early, right? If we can help remove those stigmas, that's really important as well, too, a lot through communication. And finally, the point that I think we'll have some discussion about today is, right, improving the processes and the policies with the FAA to help improve delays or the time, right, to have to be able to work, move through an approval. If you are on medication through there. So really we have those three pillars that we look at here at AOPA to try and improve that, and definitely working with the pilot community, other industry folks as well too. So looking forward to the conversation and your questions today.
Thanks, Chris. Dr. Blue.
Hi, I'm Brent Blue. I kind of look at it from a different point of view in the sense that we've had an increase in the number of depressive cases, an increase in the number of anxiety cases, but we haven't had a corresponding increased number of accidents. And so I'm looking at what happens as a result of these things. If you read my column in the AOPA magazine, the June issue, I asked people to take a survey on SurveyMonkey. And I asked just 3 questions, and it's a non-scientific survey, I fully admit that. And the first question I asked was, have you ever flown on an antidepressant and not reported it to the FAA? And as of yesterday, 47% had said yes. Have you ever obtained or failed to obtain mental health care because of the effect on your FAA medical? And 63% said yes. And then the last question was, do you think the FAA handles mental health issues correctly? And 97% said no. Now, as I said, it's a non-scientific survey, but even if it's 50% wrong or even 75% wrong, these numbers are still significant. I think that the way that pilots are evaluated for flying after reporting a depressive episode, and I'm talking about simple depressions, not major depressions and not schizophrenia or other things like that, that the evaluation is pretty archaic at this point. I think that the use of COG screen for depressive pilots is totally inappropriate, and I think that because there is such a shortage of FAA-approved psychologists and psychiatrists, that it gets to be silly that we require pilots to go to specifically certified psychiatrists and psychologists when there are lots of good board-certified psychologists and psychiatrists out there who can do these evaluations. I think that the hesitancy to certify a lot of these pilots is because everybody's worried about, oh, what is there going to be another German wings accident or something to that effect. The German wings accident, a lot of people ignored a lot of the information they had already, and there wasn't any excuse for it. That really was an airline problem, not a certification problem. I also think that we can probably delegate more of the decision criteria to AMEs, but we'll talk about that a little bit more. But that's kind of my stance on things.
Dr. Northrop.
Hi, I'm Susan Northrop. I've been the federal air surgeon for 1.5 years. Before that, I was a regional flight surgeon for close to 14 years. A couple of things that Dr. Blue said or implied is that everybody who was depressed needed to go to one of our special psychologists or psychiatrists. That is not true. For basic, minimal, mild depression, they need to get the care. So mental health conditions were very high on my list and remain high on my list of things we need to address within the FAA. Last fall, there was a mental health symposium sponsored by the University of North Dakota because they had had a student commit suicide with an airplane. The scary part to me is he didn't get the help he needed because the myth was if you ever admit to a mental health diagnosis, you will never fly again. And that's relatively close to true if you get to the point where you've attempted suicide. There are, in fact, some conditions we don't ever waive, but we waive an incredible number of them. But the trick is getting people to get the help they need early. Mild, minimal, moderate depression and anxiety are relatively easy to handle. They may take a little bit to get through our process, but we're even trying to shove some of those decision points down further to the AME. In addition, we're launching a campaign for education. How many of you have seen my pilot minutes? A couple of you. Go take a look. I have one on mental health that's out there. I've written articles, we've done seminars, we've done webinars. We need to change the mindset so that people come forward and get the help they need before they take some drastic action. Now, what about the backside? In the next year, we're going to take all of the data we have from the SSRI program, and we're going to see what can be done to make this process easier and hopefully identify some studies that we need that don't cost an arm and a leg, because I know they're expensive. Can we add more drugs? Are there other antidepressants that we can expand the list to? About 1 year ago, we hired a PharmD, and we're using her skills to help look at medications. What about ADD and ADHD? We've got a group that's starting to sit down and think about, is there a cadre of people with a history of ADD and ADHD that have outgrown it? Can we find a test or two that truly discriminates between those who had it and no longer do versus those who truly do? But it's about safety in the end. We want to get as many people in the air that it's safe for them to do. So stand by. We're trying to make a difference. If you want to hear more about some of the things that we're doing within the Office of Aerospace Medicine, come to the forum tomorrow afternoon at 4. And I'll be presenting some of those other actions.
Great. Thank you, Dr. Northrop. Gary, welcome.
Hey, good afternoon, everybody. You know, they say the last liar in the queue doesn't have a chance. So all I'm going to do is kind of reiterate some of the things that everybody else has already said. I just saw some data last night that suggests that there are over 200 million Americans who are on some type of mental health medication therapy. Well, that's that's 2/3 of our population. That's kind of scary. The good news is as everybody has iterated there, that I think we're beginning to move the needle away from the stigma of behavioral health on a societal basis, and that's certainly a good thing. To the FAA's credit, and I will give kudos and accolades to Dr. Northrup. Since she has taken over the Office of Aerospace Medicine, we've seen the general attitude about medical certification move somewhat away from the bureaucracy of safety, of course, but they're trying to be a little bit more customer service oriented, and it's a huge move to make. It's like a rowboat rudder on the Titanic. But I think Dr. Northrup and her staff are really moving in the right direction, especially on the behavioral health issues. Dr. Northrup alluded to that with the new policy guidelines on what they're calling situational depression or adjustment disorder or minor depression that in many cases now can result in an office issuance by an aviation medical examiner. That to me is a huge step in the right direction. Prior to that, we kind of, in our world, in the Pilot Information Center, we just don't always know everything about how the FAA does things. But prior to this big policy decision, pretty much anything dealing with a remote history even of mild depression, anxiety, anything, regardless of how long ago it was going to require a deferral, and then the FAA comes back with this laundry list of things that they need to see to make sure that the airman is safe to fly. So, the needle is moving, but we've got a long way to go. But I think the biggest step is eliminating the stigma now that pilots are never going to fly if they seek treatment. And as Dr. Northrup alluded to, and as everybody in this business says all the time, treat your condition first, get well, and then we deal with the medical certification end of it. So here in our Pilot Information Center, we're taking a huge number of calls from pilots anymore. The whole spectrum of even postpartum depression for women who have delivered children who have experiencing some depression symptoms and require at least a short-term course of medication, all the way up to major depression, anxiety, and certainly the more complicated certification cases too that involve bipolar illness, psychosis, and as Dr. Northrup alluded to, those don't have as good a chance of gaining a medical certificate just because of the history and the risk for the safety considerations. But all in all, our job is to kind of be the middleman, the middle people between the FAA and the airmen. So if you don't get anything out of this, and you will get a lot out of it, I'm sure, just give us a call if you have any questions about how the process works, because the key is doing your homework first. Get the information together that you're going to need to submit to the FAA. It's a lot easier for the FAA to make a decision with good information to work with, and it also eliminates the number of times that they have to come back and forth asking for more information, and that takes quite a bit of time right now with the FAA's processing issues. So it's a long process. It's complicated. It's frustrating. But the end result is, in many cases, that you can't qualify for a medical certificate, even with that kind of a history.
Hey,
Thanks.
Gary, thank you for that. I want to start with you in the Q&A, and again, I want to reiterate, if you have some questions, write them on a piece of paper, fold them forward. We'll also have some mics if you want to just ask them open, and then we'll collect them all and ask them. Gary, in the PIC, you mentioned you're kind of on the front lines there. Give us an idea, like how many calls a day would you say you get regarding mental health, and what would be like your number one question that you get asked?
Well, we get an awful lot of calls in the Pilot Information Center on obviously the whole spectrum of medical certification, but we've certainly seen an increase, I would say, since COVID especially, and that seems to be kind of the bellwether for a lot of these symptoms and what's happened since COVID. But I would say easily 50% of our calls have something to do with a behavioral health issue. And a lot of those calls deal with ADHD. And I know Dr. Northrup addressed the fact that they're looking at maybe finding a little bit better way to handle those cases. But we get an awful lot of ADHD cases. But a lot of people still call us with the expectation that they're not going to be able to qualify if they're even able to provide the information that's asked for. So again, that's part of our educational curve, is to let pilots know that, treat the condition, get well, and then we deal with the certification issue. So it's a higher percentage than we've ever seen before.
Okay. Dr. Northrup, I want to start with you, if I may. So you mentioned some of the upgrades the FAA has made or changes. Gary mentioned one, the exciting change in how you really look at situational or short-term depression, which is really exciting. What else? I know you've hired a few more psychologists on staff under your tenure. What else are you doing at the FAA?
So we have a behavioral health panel and a behavioral health division now, and it's got 3 psychiatrists, and we're looking at one more. We just lost one of our psychologists, but we're trying to hire behind. He's in the audience. I can tease him. But we have a neuropsychologist and 2 psychology positions that meet routinely to discuss complicated cases. We've shoved as much of the basic decision-making processes down to lower levels so they don't all have to come to my office. One of the things we're working on is something we call the One Guide.
The what? I'm sorry.
It's called the One Guide.
One Guide.
So right now, any of you can go look at the advocacy sites, or you can get a hold of the aviation Guide for Aviation Medical Examiners. I always call it the AME Guide. But that's online. You can go look at it. There's checklists in there. We've been adding more and more, here's what we need kind of things. But when we finish with the One Guide, a lot more will be external facing than it is right now. We're even beefing up the pharmaceutical lists that are in the AME Guide. So while I can't put internal FAA deliberations out there, my intention is to put as much as I can outward facing so that it's not a secret.
Great, thank you. So Penny, you've been treating pilots for a long time, and you and I have had some interesting conversations about stress. I came from a military background, and we were always taught that a little bit of stress improves your performance, too much stress and it bends down, but you don't see it that way.
I don't. Is it okay if I stand up again?
Please, yeah.
I have trouble connecting sitting. So I am a heretic when it comes to stress. The idea that a little bit of stress is good is actually what we think of as performance anxiety. A little performance anxiety does help us. My position is that stress, as we think of it, does not exist. And I'm going to do a real quick example. You have a non-pilot friend, okay? Your non-pilot friend gets a call from you, and you say to your friend, let's go fly, okay? And you're in the left seat, your friend's in the right seat, your friend has controls, you go unconscious. On a scale of 1 to 100, how stressful is that for your friend? Anybody? 110. Right. Okay. Now, scenario number 2. You're going out flying with somebody, you're in the right seat, your friend is in the left seat, you're both pilots. Your friend in the left seat goes unconscious. How much stress is that? Is it still 110? No, why not? Because you have specific skills to meet that stressor. The stressor is being in a plane with an unconscious pilot. It's not a 0, dude's unconscious, but it's not 100. So what we think of as stress, in my opinion, is just the relationship between the stressor and the resources that we can bring to bear on that particular stressful situation.
Great, thank you. You can keep that. Because I'm going to ask Chris. So Chris, in the advocacy world, when we're trying to push for change that we want, you need data, right? You need information. What are you lacking? What can we do?
Yeah, thanks for the question, and that's for sure. As Richard just mentioned, a lot that we do to push policy, to advance a lot of, whether it's legislation, rulemaking, policy changes, right? The FAA always comes to us asking for more data, right? And sometimes that is hard to find. Sometimes it might just be anecdotal. Now, we've already heard a lot of data out here, a lot of research that's been going out here, but there are still a lot of gaps out there, right? And one of those things that, we've kind of already talked about, one of the 3 pillars that we talked about, I mentioned about stigma, removing the stigma. Gary brought this up as well too, right? How do we connect to people? We know that with the FAA that, yes, we want to bring people in early, right? We can tell people all day long that, hey, the data shows this amount of people are typically approved. But how do we get people through that door, right? How can we connect with people? And haven't seen a whole lot of research or data that really shows what's the effective way to really do that, right? Except for, TikTok or, other social media platforms, right? We know that those are out there, but how effective are they? How can we help remove those stigmas through there? I mean, that's one example, right? But we know we have a lot of way to go for data to help us.
Good. Dr. Blue, you have been at times very candid about the system and changes that you want to see. So what would you say is your number one item you'd like to see fixed in the system?
Well, the first thing I want to point out is I think the most stressful thing for a pilot with anxiety is going through all the testing they have to do to qualify for their medical with the FAA. So that's stressful in and of itself. But I think that one of the solutions is really for the FAA to delegate more to the AMEs, whether it's under the CACI program or another program, to make more decisions about mental health issues. Most AMEs are primary care docs. They know about mental health. They treat mental health patients more frequently than psychologists and psychiatrists because they're really the first line in seeing these patients.
We need to speak up a little bit.
Okay.
Closer.
And I really think that a lot of these pilots could be evaluated by the AMEs and really streamline the process, especially if they don't have to have a checklist that every pilot has to do the same thing in order to qualify.
Okay, now it's time for your questions. Does anybody have any they want to ask or any you want to pass up? In the back of the room, do we have any floating mics? Ann? Anything? Okay. Oh, we may have, you just want to ask your question? Yeah, you'll have to shout loud. Is it on? Is that mic on?
Hello? Yeah, now
Okay.
it is. Thank you very much for this. I appreciate it. I'm a psychologist. I have a real interest in the mental health. I completely agree about the eliminating stigma. And that's a big, tall order. However, the two things I've learned that tend to combat stigma are, number one, data that you were just mentioning. But what kind of data are being collected by whom? FAA, AOPA, or who else? That's relevant to these questions. That's number one. And number two is the personal experience of pilots who have been depressed, who have then been able to fly again, and who can talk about the process and what it was like and whether there would be ways to make it better. So I think the stigma is a tall order, needs to be addressed, but my questions are, what kind of data do you need or are being collected that would be relevant to that? And is there any way to use personal experience of pilots to try to get the message out that this is something that's addressable?
I got you. So I'm going to take the second part of that first, the following up on a personal experience so that people can see what it was like and reporting on that. That's something we can do inside AOPA, and we can follow up on magazines and different posts that we do. And I think you'll see we have begun to address the topic more, not just through Dr. Blue's articles, but some others. And so I think you'll see us start to address it even more as, quite frankly, we understand the issue a little better than we need to. The data question. Anybody want to take a hack at that? She's asking, what data do you need? What data do we have?
Yeah, and kind of mentioned that already. I mean, certainly that has already been brought up here, that between the FAA and industry, there, I think, is helpful numbers out there, right? I mean, I think it's very telling from the Hoffman study that Pei brought up from last year in terms of kind of a startling number in terms of number of pilots that are admitting to withhold information on their medical or failing to disclose, right? Because now AOPA has always been, for many years, and Gary can attest this as well too, in terms of our efforts just in the broader medical certification realm. You know, we have some good numbers and data that we've been following in addition with what the FAA provides as well too. But I would say in the last couple of years, right, the mental illness has really come up with us a little bit more urgency, right? Certainly a tragic incident at the University of North Dakota last year, right? So we are lacking on some of, I think, Gary gave some here, but lacking on some of the data. And I think that through surveys, certainly that we can do through AOPA, one of my colleagues, MBAA out here, we were talking about this as well too, on how we can work as industry to obtain data, and especially information from collegiate, from Part 61, from business aviation, general aviation, right? They all can have different pressures as well too. So I guess what I'm getting at is that there are those gaps, and I think that we want to work together, surveys, work with the FAA to see where we can fill in those gaps as well too.
Yeah, I'll speak a little bit from the safety world as we try to be data-driven. I co-chair the General Aviation Joint Safety Committee with my FAA counterpart. We're very data-driven in that organization. The challenge, as you might imagine, is some 80%, somewhere in that figure, of accidents are pilot error, right? And most of those have something to do with decision making. So now you go to the third tier, which is, did something impact that decision making that is tough to detect? So that's safety data that I'd like, because it could help us in both ways. Help us sort of illuminate the kind of treatments that are helpful, that people can go get, and help us to see that this isn't what really is the size of this problem, and where does it start? And I think right now we're kind of, with the white cane poking around trying to figure that out. Dr. Northrup, anything for you on the data question?
Yeah, we got some things we're looking at. And I'll show some of the numbers tomorrow afternoon. But so when we look at total number of applications, and this year is quite frankly, the highest we've ever had. We're on track for 400,000 applications for airmen medicals, and that does not even begin to include those that are going under basic med. So that's a lot of people finally getting interested in flying again. Thank God. When you look at overall numbers, about 10% end up with a special issuance. About 1% end up with an initial deferral or denial. The vast majority of those don't pursue. But when you look at those that are final denied, it's between 0.1 and 0.2%. Great numbers, sound really good. And I was challenged recently, but what about the mental health diagnoses? And that, when you look overall, is 20 to 30,000 cases have some form of a mental health condition on their application. About 20% end up with an initial deferral. And I'm still trying to tease out the percentage that are final denied. It is higher than 0.2%, that I know, but I just don't know the upper bounds. It looks like it's going to be 5-ish%, but we're just not sure. So in the years to come, when I really get a chance, and my people get a chance to really delve into the numbers, we'll have a much better picture. At the same time, we're trying to figure out how to get a better handle on what's safe enough, because it's all about safety. And people in the throes of mental illness aren't necessarily thinking clearly and making sound decisions. So where do you draw that line? And we're going to explore that over the coming years.
Great, thank you. All right, here's one of the questions. How do you find a good HIMSS psych evaluator? How can someone find a good HIMSS qualified psych evaluator?
So if you search Find an AME, and you go through the process and you get to you're looking for an AME, there's a link on the bottom of that page that gets you to the HIMSS providers. Dr. Blue may not necessarily agree with me, but I frequently tell people that find an AME you like, or find a peer and figure out which ones they used. Word of mouth is valuable. And if you know somebody that's got a passion for this, we're always looking for more, because we do have some spots in the country that are underserved.
Great. Question, if we're currently in treatment for a mental health disorder, but on the road to stable management and hoping to one day get a medical to fly, what are some things we can make sure we document or ask from our physician or mental health provider to document now to make the process easier?
Okay, my recommendation there is that you go to the AME guide. The checklists are all there. And make sure you take those checklists into your treating providers so they see what those are. if they've put you on medication and you want to stay on the medications, for instance, we have 4 SSRIs that are currently approved, make sure that your treatment regimen is one of those approved meds. But talk to the pilot advocacy groups, Gary Crump and his bunch, and there are more pilot advocacy groups. Just make sure you go to a reputable one, and they'll help you walk through the system. But most of the information is right there at your fingertips if you have a computer.
And that AME guide, remind us again where they can find that. You mentioned that's a
If you Google AME guide, it
AME
shows
guide.
up. It's on the
Easy
FAA.
enough. Okay, all right. We have a question.
Hey, Richard.
Yes, sir. Who's that? Where's that?
Yeah, Gary. Hey, Gary here.
Gary.
The voice
Yeah.
from
The
invisibility.
voice of God coming on down.
Just one quick comment, kind of in the weeds, but I think it's worth saying that, and Dr. Northrup probably can correct me if I'm off base on this, but once you get started in this process, Dr. Northrup said, find an AME that you like. That's true across the board. Your AME can be your best friend or not such a good friend, but if it's a HIMSS AME, you really want to make sure you pick the right one with the right chemistry. And again, Dr. Northrup says we're underserved on the number of HIMSS AMEs around the country. The issue is that once you are assigned and have established a relationship with a HIMSS AME, working through the HIMSS program, be it drug and alcohol abuse, substance dependence, or SSRIs, you are joined at the hip with that HIMSS AME, and it takes probably close to an act of Congress and approval by the FAA to change HIMSS AMEs unless there's a death or you physically relocate to a different part of the country. So just select carefully. Sometimes you don't have much of a choice because the HIMSS AMEs are the HIMSS AMEs. But once you're working with that HIMSS AME, you're there for the duration.
Actually, Gary, we're making it easier to switch. But it has to be
okay.
agreed. It is a negotiated thing, and yes, we get involved.
Yes, sir.
1, 2, yes. I'm a practicing licensed clinical social worker and a psychotherapist, and I work primarily with men and with couples. And listening to all of what has been spoken of today, I had to write it down. It said, I think that what you've described about mental health and pilots,
Could you get a little louder?
what you described about mental health and pilots sounds very much like mental health of a very large segment of America's male population. Men are not particularly excited about going to therapy. The couples that I've worked with, almost 100% of them, the woman drags the man in the door, almost literally. And so I think, the doctor's numbers, your numbers they're appropriate, if not totally accurate. That it's just hard to get men into treatment. And then once you get them into treatment, it's hard to keep them in treatment. And the nature of the treatment is also very, very, it's a subtle thing. There are a lot of people who just, they go to their primary care doctor and they get some sort of antidepressant or something like that, and then off they go and they think they're done, and they may not be. The other thing that I continue to see is that some of the diagnoses are easy, but they're often, people are very poorly diagnosed. The one I see a lot, this man's nodding his head, the one I see a lot is men who were diagnosed as children or early adolescents with attention deficit or ADHD, and it's either gone or it was a bad diagnosis to begin with, but it's on their record. So they're stuck as far as what we do is concerned. So I think there's some things that need to be paid attention to. If you start looking outside of the aviation community a little bit, you're going to find that the problem is much more significant in the entire collection of people in America.
Anybody else back in the room? We'll work our way back there to you, okay? You shouldn't have to do anything with the mic, by the way. It may
Okay.
give it a second.
How's this? Everybody able to hear me?
Yep.
Okay, let's get over the stigma. My name is Jan Steinblick. I'm 73 years old, and this morning I took 50 milligrams of sertraline. That's an antidepressant. I've been taking an antidepressant a few times in my life, now most continuously since June 2nd, 2009. I own a Champ, an Aeronca Champ 7CCM. I fly it with no medical, under light sport rules. I own 2 vintage gliders. They don't have any engines. Every time we take off, we're going to have to make an engine-out landing. How do I handle that?
I'm sorry.
I'm being facetious. What I'm pointing out is that I think I do just fine as a pilot. And I used to have a second-class medical. I'd like to get a second-class medical again, and because then I would become, since I'm now retired, I'd become a CFI. I can become a CFI for light sport and for gliders, but I like to be also a CFI for airplanes. So a few things. One is when you talk about getting documentation from the providing physician, I live outside of Bloomington, Indiana. It happens to be a town of about 80,000 people. It's the home of the largest campus, the home campus of Indiana University. You would think the place would be absolutely riddled with psychiatrists to treat nice middle-class neurotics. Oh no. Oh no.
Sorry,
I've
did
lived
you
there
say
5 years.
John? Is John your first name?
Jan.
Jan, can we limit it and ask a quick question so we can move on and get some
Okay, I apologize.
Okay.
Perhaps you and I can talk a little bit later. I get my sertraline prescription from a nurse practitioner. It's hard even to get an appointment with an internist or other MD in Bloomington, Indiana. She never diagnosed me. I brought her a prescription from Washington, D.C. area. And
What's your question, Jan?
my question is, how do you handle having a provider who is not an MD?
Okay, thank you.
Thanks.
We accept documentation from all providers. The requirements in the SSRI program do require you to have a HIMSS AME, and there's certain other things, but look in the AME guide, and that should answer most of the questions.
Great, thank you. Time for probably one, maybe two more.
All right.
Yes, sir.
Hi. Thank you, Richard. Thanks, everyone. I'm the son of a psychiatrist, and I remember in the late 80s and early 90s, the ADHD meds were going out like candy. Susan, you mentioned that you guys are addressing that now, so that's good. I would really like to know, as an aspiring CFI, how does Oklahoma City rectify, and I know it's a non-certification, but how does it rectify the sport pilots or the basic med? Because we are interested in data and we are interested in safety, but how does Oklahoma City justify or rectify in its own internal thinking that we have sport pilots, basic med pilots operating Cessna 172s, Cessna 150s, but yet a third-class medical can't be issued for a lot of issues that we know exist in the pilot community?
So everything is a risk-based decision. And that's the way we approach it. Of course, you've asked a really huge philosophical question, and one that we're grappling with right now.
I wouldn't call it philosophical, but I mean, I appreciate that the FAA has done so much to sport pilot was pretty big. Basic med is huge, especially for older pilots. So I don't think it's philosophical at all. I think we're just not talking about how. I'm saying we need third-class medical reform. That's all.
I can tell you that there's a study that's coming out that's obligated when we pass basic med to have a 5-year look back of how we did, safety-wise. And when we talk about data, I think that's the kind of data that will help us in that 5-year look back when we look at basic med and how to do. So that's something that may be able to help start the conversation you're talking about. Penny, you had a response?
I would just like to add one thing to the discussion that from a psychologist standpoint, and again, I'm a CFI, I would so prefer to be in the aircraft with someone who has depressive symptoms and is receiving treatment, or anxiety and is receiving treatment, than someone who is not. And even anxiety and depression that don't reach the level of a diagnosis can run us into things like difficulties with concentrating, problems with sleep, all of which can be addressed very easily and very safely.
Great, thank you. Well, I want to thank the panelists. We're out of time, but I want to thank Penny and what you do in helping ASI and serving pilots with your diagnosis and their treatment. And Chris, in advocacy, Dr. Brent Blue, you push on the system that makes us better, and it's frustrating, but it makes us better. And what people may not know about you, Dr. Northrup, you're a pilot, your husband's a pilot, both of your sons are a pilot. So when you became the federal air surgeon, we are so happy, and we're thankful for what Gary mentioned, what you're doing inside of the medical division.
You left out my warbirds.
I want to thank you all for coming, and we'll see you at the next seminar.